Question 1. A 55-year-old male collapses. You find him unresponsive, not breathing, and pulseless. What is the most critical initial action you should take? A. Administer 2 rescue breaths. B. Open the airway using a head tilt chin lift maneuver. C. Begin high-quality chest compressions immediately. D. Check for a carotid pulse for 10 seconds. Answer: C. Begin high-quality chest compressions immediately. The concept tested here is the initial management of cardiac arrest in adults. The key is most critical initial action for an unresponsive, pulseless, non-breathing patient, which prioritizes circulation. According to AHA guidelines, prompt initiation of high-quality chest compressions is paramount to establish blood flow to vital organs. Delaying compressions for breaths or pulse checks significantly reduces the chance of survival. For example, if someone collapses right in front of you, the first thing you do after ensuring the scene is safe is to start pushing hard and fast on their chest. Remember, pushing hard and fast on the chest is the most important thing you can do initially for someone in cardiac arrest. Question 2. What is the recommended compression to ventilation ratio for a single rescuer performing CPR on an adult? A. 15 compressions to 2 breaths. B. 30 compressions to 2 breaths. C. 5 compressions to 1 breath. D. 100 compressions to 2 breaths. Answer: B. 30 compressions to 2 breaths. This question focuses on the correct compression to ventilation ratio for adult CPR, a fundamental aspect of high-quality CPR. The key is single rescuer and adult, which specifies the standard ratio. For adult victims, whether single or multiple rescuers, the ratio remains 30 compressions followed by 2 breaths to maximize blood flow with minimal interruptions. This balance aims to circulate oxygenated blood while also providing essential ventilation. Imagine you are alone with an adult cardiac arrest patient. You would perform 30 pushes, then give 2 breaths, and repeat this cycle. Always remember the 30-to-2 ratio for adult CPR, as it helps maintain effective circulation. Question 3. What is the appropriate initial energy dose for a biphasic defibrillator when treating ventricular fibrillation, VF? A. 120 to 200 joules. B. 50 to 100 joules. C. 360 joules. D. 2 joules/kg. Answer: A. 120 to 200 joules. This question tests your knowledge of appropriate defibrillation energy levels for VF in adults. The crucial keyword is biphasic defibrillator, which uses a lower energy range than monophasic devices. For initial defibrillation of ventricular fibrillation, VF, biphasic defibrillators are typically set to 120 to 200 joules, as this range has been shown to be effective. Monophasic defibrillators, if used, require a fixed dose of 360 joules. For example, when you see VF on the monitor, you would select 120 to 200 J for the first shock with a biphasic machine. Always confirm your device's recommended range for the first biphasic shock. Question 4. A patient in cardiac arrest has achieved return of spontaneous circulation, ROSC. What is the initial recommended target SBP for post-cardiac arrest care? A. SBP less than 90 mm of mercury. B. SBP greater than or equal to 90 mm of mercury. C. SBP 100 to 110 mm of mercury. D. SBP greater than 160 mm of mercury. Answer: B. SBP greater than or equal to 90 mm of mercury. This question addresses the critical immediate post-cardiac arrest management, specifically regarding blood pressure targets after ROSC. The concept is to maintain adequate perfusion to vital organs once the heart restarts. The key phrase, initial recommended target SBP, highlights the importance of preventing hypotension. Maintaining a systolic blood pressure, SBP, of at least 90 millimeters of mercury, or a mean arterial pressure, MAP, of at least 65 millimeters of mercury, is essential to ensure organs like the brain and kidneys receive sufficient blood flow. For instance, after ROSC, if the patient's SBP is 80 millimeters of mercury, you would administer fluids or vasopressors to increase it above 90 millimeters of mercury. The takeaway is to actively manage blood pressure to avoid hypotension immediately after ROSC to optimize outcomes. Question 5. You are managing an adult patient with symptomatic bradycardia. After administering atropine, the patient's condition does not improve. What is the next immediate intervention? A. Administer adenosine 6 mg for push. B. Prepare for transcutaneous pacing. C. Administer amiodarone 300 mg for. D. Perform synchronized cardioversion. Answer: B. Prepare for transcutaneous pacing. This question tests the management of symptomatic bradycardia that is unresponsive to initial pharmacologic therapy. The keywords symptomatic bradycardia and does not improve after atropine indicate the need for a more definitive treatment for inadequate heart rate. If atropine, the first-line medication, fails to improve the patient's symptoms or heart rate, transcutaneous pacing, TCP, is the next immediate intervention to mechanically increase the heart rate. For example, if a patient with a heart rate of 30 bpm remains dizzy and hypotensive after atropine, you would apply pacing pads and begin pacing at a rate that alleviates symptoms. Remember to think about pacing when atropine doesn't work for symptomatic bradycardia. Question 6. A patient presents with a regular, narrow complex tachycardia at a rate of 180 bpm. They are alert and have stable blood pressure. What is the first vagal maneuver you should attempt? A. Carotid sinus massage. B. Valsalva maneuver. C. Ice immersion of the face. D. Ocular pressure. Answer: B. Valsalva maneuver. This question focuses on the initial non-pharmacological management of stable narrow complex tachycardia. The key phrases are regular, narrow complex tachycardia and alert and stable blood pressure, indicating that the patient is stable enough for vagal maneuvers. The Valsalva maneuver, where the patient strains against a closed glottis, like bearing down during a bowel movement or blowing into a syringe, is the recommended first-line vagal maneuver due to its safety and potential effectiveness in slowing heart rate. For instance, you might instruct the patient to blow forcefully into a 10 ml syringe for 15 seconds to attempt to break the tachycardia. Always start with the Valsalva maneuver for stable SVT. It's non-invasive and often effective. Question 7. You are assessing a patient in cardiac arrest. The ECG rhythm shows disorganized, chaotic electrical activity with no recognizable QRS complexes. What rhythm is this? A. Asystole. B. Pulseless electrical activity, PEA. C. Ventricular fibrillation, VF. D. Ventricular tachycardia, VT. Answer: C. Ventricular fibrillation, VF. This question tests your ability to identify a common shockable rhythm in cardiac arrest. The critical description is disorganized, chaotic electrical activity with no recognizable QRS complexes, which is the hallmark of ventricular fibrillation. In VF, the ventricles are quivering ineffectively instead of pumping blood, leading to immediate cardiac arrest. Unlike asystole, which is a flat line, or PEA, which has organized electrical activity but no pulse, VF is chaotic. If you see this on the monitor during a cardiac arrest, it means the heart's electrical system is in chaos and needs a shock. Remember, disorganized chaos equals VF, and VF always requires defibrillation. Question 8. What is the primary purpose of capnography during cardiac arrest resuscitation? A. To confirm endotracheal tube placement. B. To monitor blood glucose levels. C. To assess the quality of chest compressions and indicate ROSC. D. To measure oxygen saturation. Answer: C. To assess the quality of chest compressions and indicate ROSC. This question highlights the multifaceted utility of capnography in cardiac arrest. The keywords primary purpose and during cardiac arrest resuscitation point to its most critical applications in this specific scenario. While capnography does confirm endotracheal tube placement, its primary purpose in cardiac arrest is to provide real-time feedback on the effectiveness of chest compressions and can signal the return of spontaneous circulation, ROSC, through a sudden increase in end-tidal CO2, EtCO2. For example, if EtCO2 values are consistently below 10 mm of mercury during CPR, it suggests inadequate compressions, prompting efforts to improve CPR quality. Pay attention to capnography, it's your window into CPR effectiveness and a sign of ROSC. Question 9. A patient is experiencing chest pain suggestive of an acute coronary syndrome, ACLS. Which of the following is an immediate priority? A. Administer 4 fluids rapidly. B. Obtain a 12-lead ECG. C. Administer amiodarone. D. Prepare for immediate intubation. Answer: B. Obtain a 12-lead ECG. This question focuses on the immediate diagnostic priorities for a patient with suspected acute coronary syndrome, ACLS. The concept is rapid assessment to guide reperfusion therapy. The key phrase immediate priority highlights the urgency of identifying ST elevation myocardial infarction, STEMI, or other acute changes. Obtaining a 12-lead ECG within 10 minutes of presentation is crucial because it helps differentiate between STEMI and STEMI, or unstable angina, and dictates the need for urgent reperfusion strategies like percutaneous coronary intervention, PCI. For instance, if a patient reports crushing chest pain, getting that ECG done quickly is the most important step after initial assessment. Always remember that a rapid 12-lead ECG is paramount for suspected ACLS to guide life-saving treatment. Question 10. You are leading a resuscitation attempt. What communication technique is essential to ensure tasks are completed and understood by team members? A. Open-ended questions. B. Repeating commands loudly. C. Closed-loop communication. D. Delegating all tasks to one person. Answer: C. Closed-loop communication. This question emphasizes effective team dynamics and communication during resuscitation. The concept is about ensuring clarity and accountability in high-stress environments. Essential to ensure tasks are completed and understood points directly to the benefit of closed-loop communication. This technique involves the sender giving a clear message, the receiver repeating the message back, and the sender confirming the message was received correctly, which minimizes errors and ensures tasks are acted upon. For example, if you say, "Give 1 mg epinephrine," the team member should respond 1 mg epinephrine given, and you confirm OK. Using closed-loop communication improves patient safety by confirming understanding and completion of critical actions. Question 11. During adult cardiac arrest, if ventricular fibrillation, VF, persists after 2 shocks and adequate CPR, which antiarrhythmic drug is recommended first? A. Lidocaine. B. Adenosine. C. Amiodarone. D. Magnesium sulfate. Answer: C. Amiodarone. This question tests the pharmacology sequence in the pulseless VF/private algorithm. The key is VF persists after 2 shocks and adequate CPR, which points to the timing for antiarrhythmic administration. Amiodarone is the recommended first-line antiarrhythmic drug for refractory ventricular fibrillation or pulseless ventricular tachycardia that persists despite defibrillation and epinephrine. It helps suppress the abnormal electrical activity in the heart that causes these life-threatening rhythms. For instance, after giving 2 shocks and continuing CPR, if the rhythm remains VF, you would prepare and administer 300 milligrams of amiodarone. Remember, amiodarone is your go-to antiarrhythmic for persistent VF after initial shocks. Question 12. What is the recommended initial dose of adenosine for stable narrow complex tachycardia that is unresponsive to vagal maneuvers? A. 3 mg for push. B. 6 mg for push. C. 12 mg for push. D. 1 mg for push. Answer: B. 6 mg for push. This question assesses knowledge of a specific medication used for stable narrow complex tachycardia. The key phrase recommended initial dose for adenosine highlights the standard starting point. For stable narrow complex tachycardia unresponsive to vagal maneuvers, the first dose of adenosine is 6 mg, administered as a rapid push, followed by a flush. If the rhythm persists, a second dose of 12 mg can be given. For example, if a patient has SVT and a Valsalva maneuver didn't work, you would quickly administer 6 mg of adenosine intravenously. Always remember the 6 mg starting dose for adenosine to convert stable SVT. Question 13. A patient presents with acute onset of weakness on one side of the body, facial droop, and speech difficulty. What is the most important initial information to determine for this patient? A. Past medical history of hypertension. B. Time of symptom onset. C. Last meal consumed. D. Family history of stroke. Answer: B. Time of symptom onset. This question focuses on the critical information needed for the acute management of suspected stroke. The symptoms describe a classic stroke presentation. The key clue is most important initial information, which relates to the time-sensitive nature of stroke treatment. Determining the exact time of symptom onset is paramount because it dictates eligibility for fibrinolytic therapy, like TPA, which has a narrow therapeutic window, typically within 3 to 4.5 hours from onset. For example, if a patient presents with new weakness, establishing when they were last known to be normal is crucial for treatment decisions. Always prioritize finding the symptom onset time for stroke patients, as time is brain. Question 14. What is the recommended rate of chest compressions per minute for an adult during high-quality CPR? A. 60 to 80 compressions/minute. B. 80 to 100 compressions/minute. C. 100 to 120 compressions/minute. D. 120 to 140 compressions/minute. Answer: C. 100 to 120 compressions/minute. This question assesses a crucial aspect of high-quality CPR, the compression rate. The concept is to provide effective circulation by ensuring enough blood flow. The keyword recommended rate for an adult specifies the target range. For optimal blood flow, Chest compressions should be delivered at a rate of 100 to 120 compressions per minute, which is fast enough to perfuse vital organs without being so fast as to compromise full chest recoil. For instance, you should aim for a rhythm similar to the song "Stayin' Alive" while performing compressions. Remember, a rate of 100 to 120 beats per minute is essential for effective CPR. Question 15. A patient is in cardiac arrest. The rhythm is asystole. What is the immediate next action after confirming asystole in 2 leads? A. Defibrillation. B. Administer atropine. C. Administer epinephrine. D. Begin transcutaneous pacing. Answer: C. Administer epinephrine. This question tests your knowledge of the asystole/PA algorithm in cardiac arrest. The key is asystole and immediate next action after confirming, which indicates the primary pharmacologic intervention for non-shockable rhythms. After confirming asystole in 2 leads and ensuring no reversible causes are immediately apparent, epinephrine is the first medication to be administered. Epinephrine causes vasoconstriction, which helps increase coronary and cerebral perfusion pressure during CPR. For example, once you identify asystole, you would immediately give 1 mg of epinephrine 4/IO, without delay. Remember, for asystole, think epinephrine and finding reversible causes. Question 16. What is the appropriate initial dose of epinephrine for an adult in cardiac arrest? A. 0.1 mg 4/IO. B. 0.5 mg 4/IO. C. 1 mg 4/IO. D. 2 mg 4/IO. Answer: C. 1 mg 4/IO. This question addresses the standard drug dose for a critical medication in cardiac arrest. The concept is to apply the correct dosage for maximum therapeutic effect. The keywords initial dose and adult in cardiac arrest specify the context. The recommended dose of epinephrine for adults in cardiac arrest is 1 mg, administered intravenously, 4, or intraosseously, IO, every 3 to 5 minutes. Epinephrine helps improve coronary and cerebral blood flow during CPR. For instance, if you have a patient in pulseless ventricular tachycardia, after the initial shock and 2 minutes of CPR, you would administer 1 mg of epinephrine. Always remember 1 mg of epinephrine is the standard dose for adult cardiac arrest. Question 17. During a cardiac arrest resuscitation, how often should the rhythm and pulse be checked? A. Every 30 seconds. B. Every 1 minute. C. Every 2 minutes. D. Every 5 minutes. Answer: C. Every 2 minutes. This question focuses on the timing of rhythm and pulse checks during CPR. The concept is to minimize interruptions to chest compressions while still assessing rhythm changes. The phrase "how often should the rhythm and pulse be checked" directs you to the standard interval. Rhythm and pulse checks should occur every 2 minutes, or approximately every 5 cycles of 30 compressions and 2 breaths, to assess for shockable rhythms or the return of spontaneous circulation, ROSC, minimizing interruptions to less than 10 seconds. For example, after 2 minutes of continuous chest compressions, you would pause briefly to check the monitor and feel for a pulse. Remember to check rhythm and pulse approximately every 2 minutes to keep CPR effective. Question 18. A patient is unresponsive with a pulse rate of 40 bpm, blood pressure of 70/40 mmHg, and signs of shock. What is the immediate intervention? A. Administer 1 mg epinephrine 4. B. Perform synchronized cardioversion. C. Prepare for transcutaneous pacing. D. Administer 0.5 milligrams atropine 4. Answer D. Administer 0.5 milligrams atropine 4. This question describes a patient with symptomatic bradycardia. The key is unresponsive, pulse rate of 40 bpm, blood pressure of 70/40 millimeter of mercury, and signs of shock, which all point to instability caused by the slow heart rate. For symptomatic bradycardia, atropine is the first-line pharmacologic treatment to increase the heart rate by blocking the vagal nerve. It's crucial to address the underlying cause of the symptoms. For example, if a patient is hypotensive and dizzy with a slow heart rate, atropine is the initial drug of choice before considering pacing if atropine is ineffective. Always think atropine first for symptomatic bradycardia if signs of instability are present. Question 19. What is the primary purpose of early defibrillation in cardiac arrest due to ventricular fibrillation, VF? A. To increase coronary perfusion pressure. B. To restore spontaneous circulation. C. To provide oxygen to the brain. D. To prevent asystole. Answer B. To restore spontaneous circulation. This question highlights the primary goal of defibrillation for VF. The core concept is that defibrillation is the definitive treatment for VF. The keywords primary purpose and early defibrillation in cardiac arrest due to ventricular fibrillation point directly to its life-saving role. Defibrillation delivers an electrical shock that attempts to depolarize all myocardial cells simultaneously, allowing the heart's natural pacemaker to resume organized electrical activity and restore spontaneous circulation. For instance, if a patient collapses from VF, shocking them quickly is the best chance to restart their heart. Remember that early defibrillation is key to restoring a normal rhythm and circulation in VF. Question 20. What is the maximum recommended time to interrupt chest compressions for rhythm and pulse checks during CPR? A. 5 seconds. B. 10 seconds. C. 15 seconds. D. 20 seconds. Answer B. 10 seconds. This question emphasizes a critical aspect of high-quality CPR, minimizing interruptions. The concept is that continuous blood flow is vital for survival during cardiac arrest. The keywords maximum recommended time and interrupt chest compressions highlight the strict limit. Interruptions to chest compressions should be minimized to no more than 10 seconds to maintain vital organ perfusion. Prolonged pauses significantly reduce the effectiveness of CPR. For example, when checking for a pulse or analyzing a rhythm, you should complete this assessment quickly, ideally within 5 to 10 seconds, and immediately resume compressions. Always remember to keep hands on chest and limit pauses to less than 10 seconds. Question 21. A patient in cardiac arrest has a PEA rhythm. After ensuring high-quality CPR and administering epinephrine, what is the next critical step in management? A. Immediate synchronized cardioversion. B. Search for and treat reversible causes. C. Administer amiodarone. D. Prepare for transcutaneous pacing. Answer B. Search for and treat reversible causes. This question addresses the core management strategy for pulseless electrical activity, PEA. The concept is that PEA is a non-shockable rhythm, and treatment focuses on identifying and correcting the underlying problem. The key phrases PEA rhythm and next critical step after CPR and epinephrine directly lead to the importance of the H's and T's. Unlike shockable rhythms, PEA responds to identifying and treating reversible causes, the H's and T's such as hypovolemia, hypoxia, tension pneumothorax, tamponade, etc., while continuing CPR and epinephrine. For example, If a patient has PEA after a traumatic injury, you might suspect tension pneumothorax and perform needle decompression. For PEA, your main job is to find and fix the cause. Question 22. What is a key indicator of effective bag mask ventilation during CPR? A. Gastric inflation. B. Visible chest rise with each breath. C. Auscultation of breath sounds over the abdomen. D. Decreased EtCO2 readings. Answer: B. Visible chest rise with each breath. This question focuses on how to confirm effective ventilation during CPR using a bag mask device. The concept is ensuring adequate oxygen delivery to the patient. The keyword key indicator points to the most observable sign. Visible chest rise with each breath is the most reliable visual indicator that effective ventilation is occurring and air is entering the lungs, rather than inflating the stomach or escaping elsewhere. For example, when you squeeze the bag mask, you should see the patient's chest visibly lift, indicating air exchange. Always ensure visible chest rise to confirm effective ventilations. Question 23. A patient is experiencing severe, crushing substernal chest pain. The 12-lead ECG shows ST segment elevation in leads V2, V4. What does this indicate? A. Unstable angina. B. STEMI, non-ST elevation myocardial infarction. C. STEMI, ST elevation myocardial infarction. D. Pericarditis. Answer: C. STEMI, ST elevation myocardial infarction. This question tests your ability to interpret an ECG finding in the context of acute coronary syndromes, ACLS. The key phrases severe, crushing substernal chest pain, and ST segment elevation are diagnostic. ST segment elevation on a 12-lead ECG strongly indicates a transmural myocardial infarction, specifically a STEMI, which means there is a complete blockage of a coronary artery. This finding requires immediate reperfusion therapy, such as percutaneous coronary intervention, PCI, or fibrinolysis. For instance, this ECG finding means the patient needs to go to the cath lab immediately. Always recognize ST segment elevation as a critical sign of a STEMI needing urgent intervention. Question 24. What is the most common reversible cause of pulseless electrical activity, PEA? A. Hypothermia. B. Toxins. C. Hypovolemia. D. Cardiac tamponade. Answer: C. Hypovolemia. This question asks about the most frequent treatable cause of PEA. The concept is understanding the H's and T's. The keyword most common reversible cause highlights the prevalence of hypovolemia. Hypovolemia, or severe blood/fluid loss, is the most common reversible cause of PEA because it leads to insufficient preload and cardiac output, even if electrical activity is present. Rapid fluid administration is the definitive treatment. For example, if a trauma patient goes into PEA, thinking about internal bleeding, hypovolemia, and giving fluids is a top priority. Always consider hypovolemia first when troubleshooting PEA and initiate fluid resuscitation. Question 25. For patients who achieve ROSC after cardiac arrest, what is the primary goal of targeted temperature management, TTM? A. To prevent deep vein thrombosis. B. To improve neurological recovery. C. To increase blood pressure. D. To reduce the risk of infection. Answer: B. To improve neurological recovery. This question focuses on a key post-cardiac arrest intervention. The concept is optimizing patient outcomes after a cardiac arrest. The keywords primary goal and targeted temperature management, TTM, point to its main benefit. TTM, typically involving cooling the patient to 32 to 36 degrees Celsius for at least 24 hours, is primarily performed to improve neurological recovery and reduce brain injury after cardiac arrest by decreasing the brain's metabolic demand and preventing secondary injury. For instance, if a patient wakes up after ROSC but remains comatose, initiating TTM is done to protect their brain. Remember, TTM aims to protect the brain and improve the chances of a good neurological outcome after cardiac arrest. Question 2-6. A patient is in cardiac arrest. After the second shock for VF, you continue CPR. When should the next dose of epinephrine be administered? A. Immediately after the second shock. B. After 3 minutes of CPR. C. During the next rhythm check, approximately 3 to 5 minutes from the previous dose. D. After the third shock. Answer: C. During the next rhythm check, approximately 3 to 5 minutes from the previous dose. This question tests the timing of epinephrine administration in the pulseless arrest algorithm. The concept is to maintain medication intervals while minimizing CPR interruptions. The phrase "after the second shock for VF and continue CPR" sets the stage. Epinephrine should be administered approximately every 3 to 5 minutes during cardiac arrest. It is typically given during a rhythm analysis pause to minimize interruption to chest compressions, ensuring it falls within that 3 to 5 minute window from the last dose. For example, if you gave the first dose right after the first shock, you would time the second dose to be around the time of the third rhythm check, roughly 3 to 5 minutes later. Always plan your epinephrine doses to fall within the 3 to 5 minute window, coordinating with rhythm checks. Question 27. What is the correct method for opening the airway of a trauma patient with suspected cervical spine injury? A. Head tilt chin lift maneuver. B. Jaw thrust maneuver. C. Oropharyngeal airway insertion. D. Nasopharyngeal airway insertion. Answer: B. Jaw thrust maneuver. This question focuses on a critical airway management technique in a specific patient population. The keywords trauma patient and suspected cervical spine injury are the crucial clues. In patients with suspected neck or spine injuries, the jaw thrust maneuver is preferred over the head tilt chin lift because it opens the airway without extending the neck, thus minimizing potential spinal cord movement. For instance, if you encounter a patient involved in a car accident and they are unresponsive, you would use a jaw thrust to open their airway to avoid worsening a possible neck injury. Always use the jaw thrust maneuver for airway opening when a spinal injury is suspected. Question 28. What is the recommended dose of magnesium sulfate for refractory VF/pulseless VT, especially in the presence of suspected torsades de pointes? A. 1 gram 4 bolus. B. 2 grams 4 bolus. C. 4 grams 4 bolus. D. 6 grams 4 bolus. Answer: B. 2 grams 4 bolus. This question tests your knowledge of a specific medication used for refractory arrhythmias, particularly torsades de pointes. The concept is about treating this specific type of polymorphic VT. The keywords refractory VF/pulseless VT and suspected torsades de pointes are key indicators for magnesium. Magnesium sulfate is the recommended treatment for torsades de pointes, and also considered for refractory VF/pulseless VT, with an initial dose of 1 to 2 grams administered for over a few minutes for patients with a pulse, or as a bolus in cardiac arrest. In pulseless arrest, it is typically given as a 2 gram 4 bolus. If you see a patient in VT with a characteristic twisting pattern on the ECG, you would prepare 2 grams of magnesium sulfate. Remember, magnesium is the drug of choice for torsades de pointes. Question 29. A patient is complaining of sudden onset of severe shortness of breath, anxiety, and has a blood pressure of 80/50 mmHg. The monitor shows a narrow complex tachycardia at 190 bpm. What is the immediate priority? A. Administer adenosine 6 mg 4. B. Perform synchronized cardioversion. C. Initiate transcutaneous pacing. D. Administer amiodarone. Answer: B. Perform synchronized cardioversion. This question presents a scenario of unstable tachycardia, and the concept is to rapidly treat life-threatening arrhythmias. The key phrases are sudden onset of severe shortness of breath, blood pressure of 80/50 mmHg, hypotension, and anxiety combined with narrow complex tachycardia at 190 bpm. These symptoms indicate instability caused by the rapid heart rate, requiring immediate intervention. When a patient with tachycardia exhibits signs of instability, e.g., hypotension, altered mental status, signs of shock, acute heart failure, ischemic chest pain, synchronized cardioversion is the immediate priority to restore a normal rhythm. For instance, with a hypotensive patient in rapid SVT, you would not delay for adenosine, you would immediately prepare for synchronized cardioversion. Always prioritize cardioversion for any unstable tachycardia. Question 30. Which of the following is a key component of effective post-cardiac arrest care once return of spontaneous circulation, ROSC, is achieved? A. Immediate administration of high-dose corticosteroids. B. Avoiding hypothermia entirely. C. Management of oxygenation and ventilation to avoid hypo/hyperoxia and hypo/hypercapnia. D. Placing the patient in a Trendelenburg position. Answer: C. Management of oxygenation and ventilation to avoid hypo/hyperoxia and hypo/hypercapnia. This question focuses on critical aspects of post-resuscitation care. The concept is optimizing physiological parameters to improve outcomes after ROSC. The key phrase, key component of effective post-cardiac arrest care points to crucial interventions. After ROSC, it is vital to manage oxygenation and ventilation carefully, aiming for normal oxygen saturation, SpO2 92 to 98%, and normocapnia, EtCO2 35 to 45 mm of mercury, to avoid the harmful effects of both too much and too little oxygen or carbon dioxide on the recovering brain and heart. For example, if a patient's SpO2 drops to 88% or their EtCO2 is 60 mm of mercury, you would adjust ventilation to bring these values back to target. Careful oxygen and ventilation management are essential to protect the brain and other organs after ROSC. Question 31. What is the primary role of the team leader during a resuscitation attempt? A. To perform chest compressions. B. To administer all medications. C. To ensure high-quality CPR and manage the resuscitation algorithm. D. To document all events. Answer: C. To ensure high-quality CPR and manage the resuscitation algorithm. This question assesses the essential function of the team leader in a resuscitation. The concept is leadership and coordination in a high-stakes emergency. The keyword primary role highlights the ultimate responsibility. The team leader's primary role is to ensure that high-quality CPR is being performed continuously, to manage the overall resuscitation algorithm, make decisions, delegate tasks, and facilitate effective communication among team members. They are the conductor of the orchestra. For instance, the team leader would say, "Time for rhythm check, give 1 mg epinephrine, and someone swap out for compressions. The team leader is critical for guiding the resuscitation and ensuring everything is done correctly and efficiently. Question 32. A patient with a sudden onset of expressive aphasia and right-sided weakness arrives in the ED. Her husband states her symptoms started 2 hours ago. She has no significant medical history. What is the most appropriate initial diagnostic study? A. Cervical spine X-ray. B. Chest X-ray. C. Non-contrast head CT. D. Carotid ultrasound. Answer: C. Non-contrast head CT. This question addresses the urgent diagnostic pathway for suspected acute ischemic stroke. The keywords sudden onset of expressive aphasia and right-sided weakness are classic stroke symptoms, and symptoms started 2 hours ago places the patient within the potential window for acute stroke therapy. The most appropriate initial diagnostic study for a suspected stroke is a rapid non-contrast head CT to rule out hemorrhagic stroke, bleeding in the brain, before considering fibrinolytic therapy, TPA. If bleeding is present, TPA is contraindicated. For example, if a patient has stroke symptoms, getting that head CT done as quickly as possible is vital to guide treatment decisions. A rapid non-contrast head CT is the first critical step for acute stroke evaluation. Question 33. What is the initial recommended intervention for a patient with pulseless ventricular tachycardia, private? A. Administer adenosine 6 mg 4. B. Administer amiodarone 300 mg 4. C. Defibrillation. D. Begin transcutaneous pacing. Answer: C. Defibrillation. This question tests the immediate management of a specific life-threatening arrhythmia. The key is pulseless ventricular tachycardia, which classifies it as a shockable cardiac arrest rhythm. For pulseless ventricular tachycardia, private, just like ventricular fibrillation, immediate defibrillation is the primary and most effective intervention to convert the rhythm and restore a perfusing heartbeat. Medications like amiodarone are given later if private persists after shocks. For instance, if the monitor shows private and there's no pulse, the very next action after confirming pulselessness is to deliver a shock. Remember, if VT is pulseless, it's treated exactly like VF. Defibrillate immediately. Question 34. What is the recommended chest compression depth for an adult during high-quality CPR? A. At least 1 inch 2.5 centimeters. B. At least 2 inches 5 centimeters. C. At least 3 inches 7.5 centimeters. D. No more than 1.5 inches 3.8 centimeters. Answer: B. At least 2 inches 5 centimeters. This question focuses on a critical parameter of effective chest compressions. The concept is to ensure adequate depth for blood flow. The keyword recommended chest compression depth for an adult is specific. For high-quality CPR, compressions should be delivered to a depth of at least 2 inches 5 centimeters but no more than 2.4 inches 6 centimeters to effectively circulate blood to the heart and brain. Inadequate depth leads to insufficient blood flow. For example, when you are doing compressions, imagine pushing down at least the width of your 2 fingers stacked on top of each other. Always ensure your compressions are at least 2 inches deep for maximum effectiveness. Question 35. A 70-year-old patient suddenly becomes unresponsive and apneic. You feel a carotid pulse at 50 bpm. What is your immediate priority? A. Begin chest compressions. B. Administer 0.5 mg atropine 4. C. Provide rescue breaths. D. Prepare for synchronized cardioversion. Answer C. Provide rescue breaths. This question presents a scenario of respiratory arrest with a perfusing bradycardic pulse. The keywords unresponsive, apneic, not breathing, and carotid pulse at 50 bpm indicate that the heart is still beating, but the patient is not breathing adequately. In this situation, the immediate priority is to provide rescue breaths to oxygenate the patient, as the primary problem is lack of breathing, not a lack of circulation needing compressions. For example, if a patient overdoses and stops breathing but still has a slow pulse, you would give them breaths using a bag mask device. When a patient is not breathing but has a pulse, prioritize providing rescue breaths. Question 36. What is the most important intervention to minimize during CPR? A. Ventilation rate. B. Pauses in chest compressions. C. Drug administration. D. Rhythm analysis time. Answer B. Pauses in chest compressions. This question emphasizes a key principle of high-quality CPR. The concept is maintaining continuous blood flow to vital organs. The keyword most important intervention to minimize points to the critical need to avoid interruptions. Pauses in chest compressions significantly reduce coronary and cerebral perfusion pressures, meaning less blood flow to the heart and brain, which negatively impacts survival. All efforts during CPR, including rhythm checks and drug administration, should be coordinated to minimize hands-off time. For example, when switching compressors, do it quickly and efficiently to avoid any prolonged break in compressions. Always strive to keep hands on the chest as much as possible. Minimizing pauses is paramount for effective CPR. Question 37. Which of the following is a non-shockable rhythm in the ACLS cardiac arrest algorithm? A. Ventricular fibrillation, VF. B. Pulseless ventricular tachycardia, private. C. Asystole. D. Ventricular tachycardia, VT, with a pulse. Answer C. Asystole. This question tests your knowledge of the fundamental distinction between shockable and non-shockable rhythms in cardiac arrest. The concept is that only certain electrical activities of the heart respond to defibrillation. Non-shockable rhythm is the key. Asystole, which appears as a flat line on the ECG, signifies no organized electrical activity and therefore cannot be treated with defibrillation. VF and private are disorganized or very rapid electrical activities that can be reset with a shock, while VT with a pulse means the heart is beating, just very fast. If you see a flat line, you know a shock won't help. Focus on CPR, epinephrine, and finding a cause. Remember, asystole is a non-shockable rhythm. It won't respond to a shock. Question 38. A patient is in cardiac arrest. You suspect tension pneumothorax as a reversible cause. What is the definitive treatment for tension pneumothorax? A. Chest compressions. B. Pleural effusion drainage. C. Needle decompression followed by chest tube insertion. D. Immediate intubation. Answer C. Needle decompression followed by chest tube insertion. This question addresses the management of a specific reversible cause of cardiac arrest, often leading to PEA. The concept is recognizing and treating H's and T's. The keywords tension pneumothorax and definitive treatment point to the appropriate intervention. Tension pneumothorax, a life-threatening accumulation of air in the chest that compresses the heart and lungs, requires immediate needle decompression to temporarily relieve pressure, followed by definitive chest tube insertion to remove the air and prevent reaccumulation. For example, if a patient with recent trauma goes into PEA and has tracheal deviation and absent breath sounds on one side, you would perform needle decompression. Recognize tension pneumothorax as a critical and treatable cause of PEA that needs rapid decompression. Question 39. What is the recommended dose of lidocaine for refractory VF/pulseless VT if amiodarone is not available or contraindicated? A. 0.5 to 0.75 mg/kg for bolus. B. 1 to 1.5 mg/kg for bolus. C. 2 to 3 mg/kg for bolus. D. 100 mg for bolus. Answer: B. 1 to 1.5 mg/kg for bolus. This question tests your knowledge of alternative antiarrhythmic therapy for refractory shockable rhythms. The concept is about having backup options when the first-line drug isn't suitable. The keywords refractory VF/pulseless VT and if amiodarone is not available or contraindicated are crucial. Lidocaine is an alternative antiarrhythmic to amiodarone for refractory ventricular fibrillation or pulseless ventricular tachycardia, with an initial dose of 1 to 1.5 mg/kg for bolus. It works by suppressing ventricular ectopy. For instance, if amiodarone is unavailable, you would prepare 1 to 1.5 mg per kilogram of lidocaine for the patient in persistent VF. Remember, lidocaine is a secondary option if amiodarone cannot be used for refractory VF/private. Question 40. A patient experiences sudden cardiac arrest. Paramedics arrive and find the patient in VF. They deliver a shock, and the patient achieves ROSC. The patient remains comatose. What is the next immediate post-ROSC intervention related to ventilation? A. Initiate hyperventilation to reduce intracranial pressure. B. Target an oxygen saturation, SpO2, of 100%. C. Titrate oxygen to achieve an SpO2 of 92 to 98% and consider advanced airway for EtCO2 monitoring. D. Administer bicarbonate to correct acidosis. Answer: C. Titrate oxygen to achieve an SpO2 of 92 to 98% and consider advanced airway for EtCO2 monitoring. This question addresses crucial post-ROSC respiratory management. The concept is optimizing oxygenation and ventilation to prevent secondary brain injury after the heart restarts. The keywords ROSC, remains comatose, and next immediate post-ROSC intervention related to ventilation are key clues. After ROSC, it is critical to avoid both hypoxia and hyperoxia, targeting an SpO2 of 92 to 98%. An advanced airway, like an endotracheal tube, with continuous waveform capnography allows for precise ventilation adjustments to maintain normocapnia, EtCO2 35 to 45 mm of mercury, preventing harmful hypo or hyperventilation. For example, if the patient's SpO2 is 99% on 100% oxygen, you would decrease the oxygen to maintain SpO2 between 92 to 98%. Fine-tuning oxygen and ventilation after ROSC is vital for brain protection. Question 41. What is the appropriate management for an adult patient presenting with a regular, wide complex tachycardia with a pulse, who is hypotensive and disoriented? A. Administer adenosine 6 mg for. B. Administer amiodarone 150 mg for over 10 minutes. C. Immediate synchronized cardioversion. D. Observe and monitor. Answer: C. Immediate synchronized cardioversion. This question presents a scenario of unstable wide complex tachycardia. The concept is recognizing and treating unstable arrhythmias promptly. The key phrases are regular, wide complex tachycardia with a pulse, and critically, hypotensive and disoriented, which clearly indicate instability. Any patient with a wide complex tachycardia who is unstable, e.g., hypotensive, acutely altered mental status, signs of shock, ischemic chest pain, acute heart failure, requires immediate synchronized cardioversion. There is no time for medications if the patient is unstable. For instance, if this patient is in rapid VT and hypotensive, you would prepare for an immediate shock, not a drug infusion. Always remember that unstable tachycardia, regardless of width, demands immediate synchronized cardioversion. Question 42. What is the recommended maximum duration for a pulse check during CPR? A. 5 seconds. B. 10 seconds. C. 15 seconds. D. 20 seconds. Answer: B. 10 seconds. This question focuses on another critical time limit during CPR. The concept is to minimize interruptions to chest compressions, as discussed earlier. The keyword maximum duration for a pulse check highlights the strict time constraint. When checking for a pulse during CPR, this assessment should be completed within 10 seconds to minimize the hands-off time and maintain continuous chest compressions, which are vital for perfusion. For example, if you finish a round of compressions and need to check for a pulse, ensure you feel for it quickly and decide within 10 seconds whether CPR needs to be resumed or if there is ROSC. Keep pulse checks brief, no more than 10 seconds, to maximize hands-on time. Question 43. A patient is in cardiac arrest, and the team is struggling to establish FOR access. What alternative route for medication administration should be considered? A. Intramuscular, IM. B. Subcutaneous, SQ. C. Endotracheal, ET. D. Intraosseous, IO. Answer: D. Intraosseous, IO. This question addresses alternative routes for drug delivery in emergencies. The concept is about ensuring rapid medication administration when standard FOR access is difficult or impossible. The keywords struggling to establish FOR access and alternative route for medication administration are key. The intraosseous, IO, route is the preferred alternative to intravenous FOR access for drug and fluid administration during cardiac arrest when FOR access is not readily obtainable. It allows for rapid delivery directly into the bone marrow, which is highly vascular. For instance, if you can't get an FOR on a patient in arrest, an IO drill can quickly establish access in the shin bone. When FOR access is a challenge, remember that IO access is your reliable backup for delivering life-saving medications quickly. Question 44. After administering a shock for VF, what should be done immediately? A. Administer 1 mg of epinephrine. B. Check for a pulse. C. Resume chest compressions. D. Analyze the rhythm again. Answer: C. Resume chest compressions. This question addresses the immediate action following defibrillation. The concept is to minimize post-shock pauses to maintain myocardial and cerebral perfusion. The phrase "after administering a shock for VF, what should be done immediately" is crucial. After delivering a defibrillation shock, regardless of whether a rhythm change is observed, rescuers should immediately resume high-quality chest compressions for 2 minutes without pausing for a pulse or rhythm check. This ensures continuous blood flow to vital organs. For example, as soon as the shock is delivered, you should immediately start pushing on the chest again for 2 full minutes. Always resume chest compressions immediately after a shock. Do not delay for a pulse check. Question 45. Which of the following is not a common reversible cause, one of the H's and T's, of cardiac arrest? A. Hypoxia. B. Hyperglycemia. C. Hypovolemia. D. tension pneumothorax. Answer B. Hyperglycemia. This question tests your knowledge of the H's and T's, the common reversible causes of cardiac arrest. The keyword "not a common reversible cause" requires you to identify the outlier. Hypoxia, hypovolemia, and tension pneumothorax are all critical, common, and treatable causes of cardiac arrest, particularly PEA and asystole. Hyperglycemia, high blood sugar, is a significant medical condition but is not typically listed as one of the immediate, direct, and common reversible causes of cardiac arrest in the H's and T's framework. For example, while you would manage a patient's blood sugar, it's not on the immediate checklist for why their heart stopped. Focus on the core H's and T's, as they represent the most common and treatable causes of cardiac arrest. Question 46. What is the recommended initial dose of synchronized cardioversion for unstable monomorphic VT? A. 50J. B. 100J. C. 150J. D. 200J. Answer B. 100J. This question addresses the appropriate energy level for synchronized cardioversion in a specific unstable tachycardia. The concept is to deliver the correct electrical energy to reset the heart's rhythm effectively and safely. The key phrases "initial dose of synchronized cardioversion" and "unstable monomorphic VT, ventricular tachycardia with a uniform QRS complex" are crucial. For unstable monomorphic VT, the recommended initial synchronized cardioversion energy is 100 joules, biphasic. If this is unsuccessful, subsequent shocks are typically higher. For instance, if you have a patient in unstable monomorphic VT, you would set the defibrillator to deliver a synchronized shock at 100 joules. Remember to use 100J as your first synchronized shock for unstable monomorphic VT. Question 47. You are performing CPR on an adult patient. The EtCO2 reading on the capnograph suddenly increases from 15 mm of mercury to 45 mm of mercury. What does this likely indicate? A. An esophageal intubation. B. Poor quality chest compressions. C. Return of spontaneous circulation, ROSC. D. Ventilator malfunction. Answer C. Return of spontaneous circulation, ROSC. This question tests your understanding of capnography as a real-time monitor during cardiac arrest. The concept is recognizing physiological changes that indicate a positive outcome. The keyword "suddenly increases" from a low value, 15 mm of mercury, typical during effective CPR, to a higher, more physiological range, 45 mm of mercury, is the crucial clue. A sudden and sustained increase in end-tidal CO2, EtCO2, to values typically greater than 35 to 40 mm of mercury during CPR is a strong indicator of return of spontaneous circulation, ROSC, because blood flow, and thus CO2 delivery to the lungs, has significantly improved. For example, if you're doing CPR and suddenly see the EtCO2 jump up, it's a great sign the heart might be beating again. A sudden jump in EtCO2 is often the first sign of ROSC during CPR. Question 48. What is the recommended rescue breathing rate for an adult with a pulse but not breathing adequately? A. 1 breath every 3 to 4 seconds, 15 to 20 breaths per minute. B. 1 breath every 5 to 6 seconds, 10 to 12 breaths per minute. C. 1 breath every 8 to 10 seconds, 6 to 8 breaths per minute. D. 1 breath every 2 seconds, 30 breaths per minute. Answer B. 1 breath every 5 to 6 seconds, 10 to 12 breaths per minute. This question focuses on appropriate ventilation rates for a patient in respiratory arrest with a pulse. The concept is to provide adequate oxygenation without causing hyperventilation. The keywords adult with a pulse but not breathing adequately specify the situation. For an adult with a pulse but inadequate breathing, provide 1 rescue breath every 5 to 6 seconds, which totals 10 to 12 breaths per minute. Excessive ventilation can be harmful by increasing intrathoracic pressure and reducing blood flow to the heart. For example, when using a bag mask on a patient who has a pulse but is not breathing, count slowly to 5 between each breath you deliver. Remember to give slow, regular breaths every 5 to 6 seconds for adults with a pulse but no breathing. Question 49. What is the initial dose of atropine for symptomatic bradycardia? A. 0.25 mg for. B. 0.5 mg for. C. 1 mg for. D. 2 mg for. Answer, B. 0.5 mg for. This question tests the initial drug dosage for a specific bradyarrhythmia. The concept is about the first-line pharmacologic treatment for symptomatic bradycardia. The key phrases initial dose and symptomatic bradycardia are crucial. The recommended initial dose of atropine for symptomatic bradycardia is 0.5 mg given intravenously, as a bolus, and it can be repeated every 3 to 5 minutes up to a total dose of 3 mg. Atropine works by blocking the vagus nerve's effects on the heart, thereby increasing the heart rate. For instance, if a patient is hypotensive with a heart rate of 40 bpm, your first action after supporting their airway would be to give 0.5 mg of atropine. Always start with 0.5 mg atropine for symptomatic bradycardia. Question 50. During post-cardiac arrest care, what is the target range for mean arterial pressure, MAP? A. Less than 60 mm of mercury. B. 60 to 65 mm of mercury. C. Greater than or equal to 65 mm of mercury. D. Greater than 100 mm of mercury. Answer, C. Greater than or equal to 65 mm of mercury. This question focuses on another vital hemodynamic target in post-cardiac arrest management. The concept is ensuring adequate organ perfusion after ROSC. The keyword target range for mean arterial pressure, MAP, identifies the specific parameter. After return of spontaneous circulation, ROSC, it is crucial to maintain a mean arterial pressure, MAP, of at least 65 mm of mercury to ensure adequate perfusion to vital organs, especially the brain and kidneys. If MAP falls below this, vasopressors or fluids may be needed. For example, if your patient's MAP is 60 mm of mercury after ROSC, you would intervene to raise it above 65 mm of mercury to protect their organs. Always aim for a MAP of at least 65 mm of mercury after ROSC to optimize organ perfusion.